for our community of Grey and Bruce. Any further discussion on these minutes? Can I get a mover and seconder to adopt these minutes? Brian Millen, and I'll take Brian O'Leary. All in favor? That's carried, thank you. Item 7 is correspondence and news releases. We'll start with the correspondence. Dr. Era, please.
Thank you, Madam Chair. There are 4 correspondences on the correspondence items on the list for this month. The first one is from Chadwick Kent, and it is related to the opioid crisis. The board of Chadwick Kent is asking the Premier for Ontario to declare the opioid crisis as an emergency. And the recommendation there is to receive. The second one on the list is from Niagara region, and it is related to improving air quality to prevent COVID-19. And there is a call to adjust or amend the National Building Code and Ontario Building Code to achieve that effect. And the recommendation also is to receive the Miskaming Board, the Premier, the Minister of Health for Ontario, to endorse its endorsement of the letter from Simcoe Muskoka, an item that was circulated early in the spring, in March 16th letter, where it called on the province to create a task force for dealing with the opioid crisis. And the last item is from the Miskaming Board of Health, and it's addressed to the Federal Minister of Health, and the board support call on the government, the federal government, to decriminalize illicit drugs. So the recommendation there is also to receive, Madam Chair. Open to any questions or discussion on these items.
Thank you. Are there any questions or comments for Dr. Era? Okay, we will move on. I see Denis there. Denis, news releases, please.
Thank you, and Madam Chair, and through you, there are 3 news releases on today's agenda. 2 relate to COVID-19 vaccination and public health work in supporting residents in getting up to date on their vaccines. Both speak to the importance of vaccination, which is the best defense against severe outcomes from COVID-19 and most effective way to protect communities. They also discuss the vaccine clinics planned by public health, including supplementary clinics organized through a partnership with GoVax. The second release focuses on provincial and federal updates related to COVID-19 vaccines. Health Canada authorized the first COVID-19 vaccine for children aged 6 months to 5 years, while Ontario expanded eligibility for second booster doses to all residents aged 18 and over. And the final release is regarding the first laboratory confirmed case of monkeypox in Grey Bruce. The person diagnosed resides in Grey Bruce, but most likely acquired the infection while visiting the Greater Toronto area. Public Health's infectious diseases team, under the leadership of Dr. Era and Dr. Zayed, worked quickly to identify this individual's close contacts and ensure all were properly isolating, and no further cases have been identified.
Thank you, Denis. Are there any comments or questions about the news releases? Seeing none, I'll take a mover and seconder to approve the correspondence and news releases as presented. Moved by Alan and seconded by Helen Clare. All in favor? That is carried. Thank you. Item 8 on the agenda is the Medical Officer of Health update, and we'll start with Dr. Era, please.
Thank you, Madam Chair. So I'm just gonna share my screen, share with your permission. So, Madam Chair, this is a set of data from the province that comes weekly, and it reflects the past week or 2 weeks of data, depending on the slide. I'll just go through 4 or 5 slides of them. I believe they will provide good information on the situation in general. This is a jurisdictional comparison among a number of global picture, number of jurisdictions throughout the globe. New Zealand, you can see France, there's quite the number of known cases standardized by 100,000 population. So all these jurisdictions data is standardized. And this New Zealand increased from 1,000 to 1,500 or above. We look at Alberta, Manitoba, on the other side of the spectrum, very low activity. It's worth mentioning the green color means the jurisdiction data or number of known cases is decreasing. The trend is decreasing. The blue is increasing. We see Ontario is very close to the lowest levels. It is increasing though, and that's in the trend is between July 1st to July 14th. So that's in general where Ontario sits globally. If you look within Ontario, each one of these columns is a health unit. I whited out the names of the health unit except for Grey Bruce. You can see that there is not much difference among health units. The difference is not statistically significant. There's only one health unit that has significant difference up there to the far left, but there could be many reasons for that data to be that way. Grey Bruce is increasing, it's in the blue. However, it remains actually the lowest transmission in the province, and that's from, again, July 4th to July 17th. There is some difference sometimes in the data among, or the window of time among these slides, but all of them are from the past week or two. This is the location of outbreaks in the province, and whether it's in the educational sector or the congregate settings, long-term care. Between this should be from about the same time frame. Currently, we have 3 outbreaks in long-term care, but at the time of this map, there was none. And there is a total of 133 outbreaks. So again, Ontario in general, there is some increase, but the numbers remain very favorable for low transmission. Recent outbreaks in the province, as so the light blue is the current outbreaks in the past 7 days. The deep blue is the past 28 days. Many of them have already cleared, and you can see the majority of these outbreaks are in the high-risk sectors, long-term care, retirement home, hospitals, mainly because that's where the focus is. Obviously, schools are closed, so that reduces that significantly. There are still reports about outbreaks that are significant, whether it's on farms or other, but it is very small percentage. This is just a useful graph actually to look at the percent positivity by age group. We get the question many times from the public or the media, percent positivity, and it's going up, it's going down. It's not a good metric to look at one day or to look at what happens on that specific location. There is quite the variability in calculating percent positivity, especially if you're testing people without symptoms. If we test today 20,000 people in Grey Bruce without symptoms, the percent positivity will go down, plummet to close to 0, but that doesn't really change the fact that there is transmission. But one use of the percent positivity is in a graph like this, where the lighter the color towards, if you look at the far right, there is a scale. The yellow light means high percent positivity. Dark color is the yellow color, sorry, not light. The dark color is low percent positivity, and by age group on the far left, the older the person is, the higher on the scale they are on that axis. And on the x-axis on the bottom, it is by month from November till now. And from this graph, I can look at and immediately say there is higher transmission percent positivity in the age group between at this point in time in July It is between age 18 to age 55. It is not very high. According to the color, it is around 15 to 18% positivity. But this age group is where the bulk of the transmission. And just for applying the same principle, if you look at December and January specifically, and you look at the younger age group at the bottom of the graph, I can actually mark it down here. These are the 2 weeks that preceded the lockdown that was issued by the province, and the schools were included. And you can see if there are more transmission around this time, around the holidays, the transmission again happened in that age group, mainly between younger age group, actually from 4 to 45. My point from this slide to our audience, people who are listening, that percent positivity is not a number you can just look at and judge a place or judge an outbreak. It comes in a bigger picture, looking at the geography, at the age, and looking at certain calculations that would allow a person to use it and become of utility. And Madam Chair, I'll stop sharing there. And regarding the situation in Grey Bruce specifically, verbally, I'll provide that. We have currently 3 outbreaks in long-term care, a couple of outbreaks in retirement homes. We've seen an increase in the transmission of the disease, but it is minor transmission, an increase of number of new cases. The number of deaths has not increased. It's actually in the province has decreased in the past few weeks. There is definitely the anxiety with the reports that we received that there is some increase in certain parts of the province. We continue to monitor and connect with the ministry. At this stage, there's no need to change our course. We anticipate increase or surge in the fall. That is anticipated, but again, that will be in the number of new cases. Is that going to translate into hospitalization or ICU? Again, that's something to be seen. We'll monitor for. Worth mentioning that the healthcare system in general is overwhelmed, even though there isn't the number of hospitalization that justifies it, and that comes for many reasons. People retiring in the healthcare system, the working remotely might be a component. That's my own bias. People returning to work, there is definitely difference in the performance there. In all cases, we will continue to monitor the situation related to COVID, and we communicate with other health units, definitely with the province, and we'll keep the public and Grey Bruce up to date. Any question on that, Chair?
Thank you. Helen Clare.
Thank you, Madam Chair. Through you, thanks to Dr. Ara for that the report. The anxiety that's out in the community, I think, is inflamed by us not giving sufficient and balanced information. And what I mean by that is just having or emphasis on test positivity doesn't really give us the full picture. That's what I'm understanding from the snapshot Dr. Ara just provided. Yes, there are outbreaks in congregant settings, and that we saw the graph with that, but how many of those result in serious outcomes? You know, how many of those are asymptomatic, in which case it could be 100% positive, but if none of them have any symptoms, I'm being facetious to make the point, then it really is not something of concern. And yet that's the information that tends to be out there. It would be really great if alongside these positive testing results, we actually could have a breakdown that would show the numbers that are asymptomatic, the numbers that have symptoms. Of those that have symptoms, how many of those are serious, result in serious outcomes, such as hospitalizations and death? Right now in the media, it continues to be inflaming the numbers of positivity without the context. And that's why I believe there's so much anxiety. And with regard, if I may, Madam Chair, to the medical, our system being under threat, by definition, we don't run public health like there's always an emergency. Otherwise, we couldn't afford to do that. All our resources would be there. But again, the idea in the community is that it's all because of COVID. And so I really feel, not this unit, communications in this unit is always extraordinary, but I think we could do a better job. And it's just a source of frustration for me when I see the news releases from the province or across the country, whipping up fear, in my opinion. Thank you, Madam Chair.
Thank you. Dr. Aaron, did you want to comment or?
Thank you, Madam Chair. I agree with everything Helen Claire mentioned. And, even for our health unit, we do our best to communicate the information that the public needs, but at the same time, the information that is going to help the situation. And in this case, if we communicate about the number of cases and breakdown of everything like we did before on the SIT report, it's guaranteed we're going to increase the anxiety in the public, because people were going to start looking at these numbers and some people might misinterpret them. Worth mentioning, we have our dashboard on the website for the public to see all these numbers. It's not good practice to break them down every day and send them in a media release at this stage. For the past, I would say since February, there are outbreaks in long-term care. Most of these outbreaks have not resulted in death that is premature. People who are dying, people who would be dying anyways of cancer, 4th stage or 3rd stage. So these outbreaks in general, they are not severe. The absolute majority of long-term care residents who get infected recover with no symptoms after. So, and these are the most vulnerable. So again, I think Helen Claire said it best. Yes, there are a number of cases, but what does that mean as a burden to the healthcare system or burden to health in general?
Thank you. Alan?
I mean, that's a good discussion. And I think I'm just trying to summarize and see where the best approach is going forward. And I think you're doing exactly what I'm going to suggest. Like you're right, the media played as if we're going to have a 7th wave and it's going to be this big. And you're saying, we're not going to be there like to anything that's really severe. But I think from the media that I've read locally, but once a week, they do an interview with you and you're saying like, we're pretty stable in this area. So to continue on with that path, I think that's a good way to go. Anybody that's following it will follow then that locally it's not a big issue. To try and do that daily, you're going to lose the focus of everybody on it. So as I say, I think just to reiterate, doing it like on a weekly basis type thing locally is probably keeping the concern at the level that it should be.
Through you, Madam Chair, I agree with that. Definitely, that's the pace that we're looking at. And similarly, on social media, there is always a discussion: how much do we need to respond to these people who are saying don't put the information? And one of the solutions is to provide all the information here in the board where there is media watching. So anytime there is somebody on the social media will say what's happening with this, you can reference this meeting. So there is communication from different channels on that. Worth mentioning, Madam Chair and board, that we don't know what's going to happen in the fall. There could be a different variant. We continue to monitor, but at this point, there is no need to change course or respond in a different way.
Okay, Brian Millen.
Thank you, Madam Chair. And just to speak to Dr. Ayer's final point there, we don't know what's going to happen this fall. The other end of the spectrum regarding anxiety is I daily run into people that say, don't worry about it. I'm going to wait till the fall to get my 4th booster or 3rd for that matter, because, there's suggestions that the booster in the fall may include, some technology regarding the BA.5 variant, whereas currently there isn't. So they're saying, well, if the BA.5 is mostly what's out there, I'm going to wait until the fall to see what the booster's made of. Is that? I'm not sure exactly how to phrase the question, but is that something, or is that a strategy necessarily, Dr. Era, that is sound, so to speak?
Through you, Madam Chair, that's a question that brings a very excellent subject. The staying up to date, that's probably the easiest way to say it instead of third and fourth, because it's different for different people. Protection, half protection today is better than full protection tomorrow. That's my advice. And people who qualify for a third or fourth dose right now will also qualify for the new vaccine if that vaccine was available in the fall. So a person is not struggling with ultimatum today or in the fall. Rather, it's a matter of also both or also in the fall. So my advice would be for people to stay up to date, and obviously the vaccine is very safe. We have experience globally of millions and billions of vaccines, and the portfolio of the vaccine is very safe. Now there is the vaccine for children, and again, our clinics, I should have mentioned that in my update. We continue to provide clinics throughout Grey Bruce, focusing specifically on the areas that have less coverage through primary care or pharmacy, but people can go to their family physician, they can go to their pharmacy, or to the public health clinics throughout Grey Bruce.
Thank you, sir.
Okay, we'll move on. Thank you, Dr. Era. Item 8.2, modernization. Is there an update?
This item, Madam Chair, stays dormant. There is no update from the Ministry.
Thank you. Dr. Zayed, the opioid situation in Grey Bruce.
Thank you. I just want to give a quick update on the opioid crisis, and this include an update about this committee that has been developed. Next slide. As I mentioned in the last meeting, there was the common work group that was developed in response to the opioid crisis to highlight the role of public health. And this common work group is chaired by Semco Muskoka Health Unit, with membership from Public Health Unit, advisors from Public Health Ontario and Ministry of Health, and partnership and collaboration is open to any national, provincial, municipal organization. Next. This work group advised on 9 priorities that have been adopted by the Alpha Resolution, and this was the main 9 priorities is multi-sectoral task force, access to harm reduction program and practices, enhances the sustainability and support for substance use prevention and mental health promotion initiatives with a focus on early childhood through to adolescence. And you can see I have added, I bolded this priority, and also the 4th priority related to data, which is a collection, analysis, and timely integrated epidemiological data. The 5th priority is related to therapy, and the 6th priority related to stigma and discrimination, and that creates systematic barriers for people who use drugs. And the 7th is related to advocacy, and to decriminalize personal use The ninth, the eighth is related to the social determinants of health, systemic racism. And the ninth priority is consistent community leadership, and including people who use drugs and by community organization. From these 9 priorities, there are the priority related to the sustainability for promotion related to youth, childhood and adolescence, the third one, and the data collection, and the one related to community leadership by people who use drugs. These 3 priorities are included, or the main determinant of the new group or the subgroup that we co-chair. So next slide. So we wanted, so this prevention subgroup committee, we were talking about it, is it a committee or a work group? So we decided it will be a standing committee, and with leadership from Grey Bruce Health Unit and Public Health Ontario as a partner, and this focus mainly on this area where we know that the crisis is a spectrum. It started from prevention and also to harm reduction at the end of the spectrum, and facilitating the treatment. So if we started to really focus on the social determinants of health, focus on adverse childhood experience, that will give us more grasp on this crisis on a long-term basis. So that's the main idea of this committee. The membership of 9 health units, including Toronto, Waterloo, Peterborough, Kingston, Southwestern, Simcoe, Muskoka, Grey Bruce, Brant County, and York. There is a variation in this group. Some are urban, some are rural. So with exchanging of these experiences and collaborating together in the prevention side, I think it will be very helpful. Next is related to the objectives. So the main objectives are 4 objectives: is evidence-based intervention for the prevention. So any intervention we use should be very evidence-based and focus on adverse childhood experiences. So adverse childhood experiences, or ACEs, there are lots of input of evidence around this. We have some evidence from Wales and CDC and Alberta Family Wellness, 3 very good reports that showed how the adverse childhood experiences influence the outcome of drinking, like 20 times. People who had adverse childhood experience have 20 times experience in or outcome, adverse outcome related to addiction, and other, it's really a very 3 good reports that we are going to use as evidence for the intervention. And it's worth mentioning also that we are starting locally in the public health unit some more work in partnership with other partners working for this age group for the prevention, and I'm going to mention that later. Understanding the evidence-based intervention and how to integrate social determinants of health. We have seen through experiences how housing can influence employment, all structural discrimination. So this is an important part to focus on marginalized population and the priority population at this from that context, from social determinants of health before actually going through that outcome. described also the current programming in Ontario. We have many programs working on either the same thing or similar or something related. So having this understanding and at a provincial level of all the program relevant to this and try to streamline this work, it will make a stronger action and a stronger advocacy for that work. And finally, the logic model and framework to map areas of coverage and gaps. So when we have a logic model, we know the components of work. We can really underline where are the gaps, and that will overlap with mental health promotion as well. And after we underlined the objectives, next is related to deliverables. So there are some deliverables that we thought that in 1 year, we need to work in this. At the end of the year, we need to achieve this deliverable. And they are related to 3 important points: the environmental scan of early child and youth program, data summary and knowledge exchange of the current epidemiology, and that include analysis from data from Public Health Ontario and the EPI group, which is another group than the opioid or drug addiction. This is a group working on data. In Public Health Ontario will work with us and consider also all the data from public health units so that we can integrate this data and analyze them, and consider analyzing and evaluation of this data. The other important data piece is related also to knowledge exchange on characteristic of opioid death. And that will include also working with Ontario Drug Policy and Research Network and working with the Office of the Chief Coroner. And finally, the third deliverable is a grant, consider a grant proposal for conceptual framework. And this is actually something that we are starting to work on right now, even before the first meeting of this group. But there is a grant from Canadian Institute of Health Research, CIHR, with a deadline in September. So we are working on, even before meeting with the members, on preparing this conceptual framework. Next is a local. So how we are going to benefit from that locally in Deliverables. So first of all, we started, as you know, the foundational standard team. We start with the matrix structure management. So one of the important priority projects that we identify is human health prevention across the lifespan matrix. And this is starting from 0 age till senior. So the part that is related to 0 to school or preschool age and from preschool to school, this is the part that will benefit from this kind of prevention group and highlighting the evidence-based intervention for this group. And that's working with Healthy Baby, Healthy Children, Healthy Growth and Development team and the school health team and harm reduction. So this team will work together across the organization rather than working in silo. And the other thing is there are other partnership with CAMH, some project that we are working on it right now called Handle with Care. And this is a prevention program that is really focusing on adverse childhood experiences. Also, the other local context that will be really very helpful is people with lived experience. So we can optimize integrating people with lived experience in our work. And that's really, we have different groups working with people with lived experience. So trying to integrate all these groups and have some evidence-based intervention from their experience would be very helpful. Evidence-based intervention for the current project of partnership, including the community delivered project like SOS. An evaluation of this project also is very important to identify areas of strengths and areas of weakness, and how we can identify this weakness and or lesson learned from it, and improve and work on improving it. So that's my update. I think that's the last slide.
Thank you, Dr. Zaya. Brian, you have a comment?
I do. Thank you, Dr. Zaya. That's a great presentation. Just wondering if you can expand on or talk more about adverse childhood experience. Like, what all does that involve?
So that involves positive parenting, either positive or, like, again, with that parenting will be negative parenting, lack of access to service, early screening for any adverse issue related to growth and development for childhood, domestic violence, trauma. So all these things, and there is really a big report that I can also share with the board about the evidence of how this childhood experience, like, for example, drinking at home or any kind of trauma or adverse effects, lack of attention, or even parenting and behavioral issues that affect really, like, it's really amazing to see how this affect the behavior later on. So this project will focus on that part from 0 to 4, and then there is also an extension to that in school and for the school age group. And that also comes with our team coming back to school in a pilot study for a school health team or school-focused nurses going back to school for the high school for 1 year pilot project. And I am really proud to say that they prepare their evaluation matrix before starting of the project. This is something which is rare. Sometimes people do the evaluation after they finish, but I am impressed that the school health team actually prepared their evaluation matrix before starting of the program. And we will evaluate that pilot study at the end of the school year.
Okay, any reports you have on that, I would love to have.
I will send you, yeah, the Wales report is really impressive about the evidence. They have been working very heavily on that, and this is one of our important references.
Thanks so much. Thanks, Madam Chair.
Any other comments or questions? Helen Claire?
Thank you, Madam Chair, through you. Dr. Zayed, thank you for that great presentation. And what I have to say might not be appropriate, so I'm going to invite you, please, to jump in and say if it isn't, because perhaps what we've just seen is a high overview, and my comments might be too much in the weeds. So please, I do not want to take up the board's time with inappropriate comments. If I'm going down the wrong path, Madam Chair, through you, I would invite Dr. Zayed, please, to just interrupt me. My concerns, though, are I'm seeing a gap in the adverse childhood experience portion that seems to, in my opinion, miss out the family unit. It isn't, respectfully, I don't think it starts at 0, it starts during pregnancy. And often these family units are struggling with intergenerational trauma. So it really goes back quite far. I mean, obviously with Indigenous groups, but not only. People who have generations of poverty or sometimes criminality or other situations that have made family units suspicious of authority figures and public agencies. So it makes it very difficult when dealing with an individual through that lens if one doesn't look at the whole family unit, because what one does not want is an externally applied or seemingly externally applied rescue situation to try to solve adverse childhood experiences, because if it does not include the family, it's at great danger of removing the buy-in of the family into the entire, the whole concept of ACE is to try to help that family. But if it seems external, then it won't happen. It's much more likely to raise the hackles and the suspicions, and therefore adversariality in that family unit. If a family unit thinks it's going to have its agency removed on how it's raising its children, rather than being partners at the table to look, you have some challenges, let's work with you. So I wanted to say that, and I also wanted to add that some statistically adverse childhood experiences are related to foster care, which of course, again, is not in isolation, is often a product of taking a child out of a home because the home is not able to manage, but then putting the child in foster care. Sometimes foster care makes it worse. So this is very complicated, this section of adverse childhood experiences. And again, I apologize if I recognize that an overview has been provided, but I wanted to say this whole stuff that I've just packaged, just dropped here, I think is extraordinarily important and something that needs to be woven in right at the beginning. Thank you, Madam Chair.
Dr. Zayed?
Through you, Madam Chair. Thank you, Helen Claire, for this valuable comments. And it's just an overview, so I just didn't go into details. Of course, we are dealing with the families and not through a very narrow lens of adverse childhood experience. We deal with families having a background of screening or trying to highlight the positive parenting. And as I mentioned, it is a proactive. It's a proactive approach. So trying to avoid that, not to try to deal with that. Again, we don't want this fixing things or solving things. We want to have an experience, provide a good family experience from the prenatal part, which is part of our Healthy Baby, Healthy Children. And this is in terms of family unit, in terms of providing the good assets or using the positive assets, but in the same time, keeping in mind what would the adverse things would happen. I totally agree with you about foster care. This is not a great experience in general. It is helping family to be good parents and helping them to have a good experience, because there are many things that are learned and there are things that we need to help them to have this experience. So it is a support, a proactive approach from the prenatal part, and actually also working with young people in schools and high school, prepare them to have these positive assets as well. There are lots of positive assets that will be included in that program. So maybe working with about recreation, about positive parenting. So trying to model, but not really discriminate. Again, it is a very complicated, as you mentioned, it is complex. So trying to not to add stigma or marginalize people or stigmatize them in groups or categories. So it is all taken care of. So, and I just want to add some statistics about from the Wales group that worked on that. There are 4 times likely to be high risk drinker if with adverse childhood experience, 6 times more likely to have received the treatment for mental health, 6 times more likely to be a smoker, 15 times more likely to have been involved with violence, and 20 times more likely to have been incarcerated. So it is just a way of how to be proactive and help people and support them to have these positive assets in their life.
Thank you. Dr. Era.
Thank you, Madam Chair. I want to echo everything Dr. Zayed mentioned, and I want to add, I really appreciate the question, Helen Claire. Like the presentation that we put forward or the reports, sometimes they need to be high level, but there are multiple layers that are translated to the front line or to the public. One of them is we have a number of professionals on our teams, nurses who are specialized in dealing with, for example, the healthy baby, healthy children with disadvantaged families or single mom family or single parent family. And they go about implementing the interventions in the most friendly, family-friendly, professional way a person can imagine. I can give an example even about their dress code. We have dress code policy to have a professional dress code, but there is an exception in that policy for that team because they need to connect with the people. So they need to wear clothes that is very comfortable instead of coming in the image of establishment or a suit versus jeans with a t-shirt. So they look at many aspects that are beyond my ability to list in 2-3 hours. So that's one aspect, how this is translated to the front line. The other aspect is circling back to the health promoters. Health promoters don't work in that program, but they support it. And for example, our dietitians will provide advice to our nursing team to pass to the parents or to the mom who's taking care of a baby or potentially is going to be pregnant and provide all the advice about the nutrition. Smoking or drinking during pregnancy can result in lifelong health problems for the infant. So again, we focus on many aspects of it beyond the report that we put together as a high level.
Okay, Brian O'Leary.
This discussion could go on forever. Like I really enjoy listening to all this. It's so interesting, but the more I hear, the more I think maybe we should start even before that. You know, it makes me think of the mother and father that are sitting down discussing having kids. There's so much involved, and you find out some things in a hurry. Like as a father, I joke about it all the time, but you find out as a father, you play second fiddle in a hurry. And you know, the mother takes over and it's her and the kids, and it's like there's a lot of guys that probably couldn't handle that transition. And I just wonder if, you know, if there's some kind of education that would help in that.
It's for you, Madam Chair. That's a really great point. And when I say human health development across the lifespan, that would include men health and women health, and which include premarital counseling as well. So it's all there.
Through you, Madam Chair, at school, the school programs actually address this. People who are 14, 15 years old, they're exposed to this knowledge and they grow up with it. It's not specifically that a person got married and now, or they're partners and now we're going to give them this advice. Health promoters actually insert this in the school curriculum at many levels. Again, many people benefit of it differently, and we can always improve. And sometimes it's like, this is the beauty of public health. You can give folate to a person who is planning pregnancy and prevent neural tooth defect, which is the person will be disabled for life if they're born with that. It's just a simple intervention today that's going to prevent and save taxpayer money and community struggle for years down the road. And we can always invest into prevention instead of after the fact prevention.
Okay, very good discussion. We can probably come back to that again if we're ever looking for something. So thank you, Dr. Zayed and Dr. Era. Let's move on. Item 8.4, submission to proposed vaping product reporting regulations.
Madam Chair, this is a brief item, and there was the direction from the board endorsement to the tobacco group in the Southwest to submit to the Health Canada to implement more stringent regulations and legislations related to vaping. So that happened, and this submission is a follow-up on it based on the recommendation from the same group, whether it's related to nicotine concentration, flavor, and additives to vaping, the request for more coordinated inspections between the provincial and the federal level, and safety profile of these products. And with your permission, Madam Chair, I'll invite Dr. Zaid if she would like to add to this update.
Thank you, Dr. Through you, Madam Chair. It is actually the regulation is related to vaping, but the addition here is related to the ingredients and the point of sale. So this will urge the companies to disclose the ingredients and to disclose the sale, the sale characters for this ingredient, so that there are options for the consumer, even not in a younger age group. Even those who consume vaping should be clear about what they are consuming.
Great. Any comments or questions for either Dr. Era or Dr. Zaya? All right, very good. So I need a motion to receive the updates as presented. I need a mover and a seconder. Brian O'Leary and Brian Millen. All in favor? That is carried. Thank you. Next on the agenda is our corporate services report, and we have Kim with us to present the financials as of May 2022. Welcome, Kim.
Through you, Madam Chair, this is the May financial update. At the end of May, we had a surplus of $289,000. Most of this was from the Senior Dentals Program, which had the large construction project at the beginning of the year. And the remaining surplus was our other non-Ministry of Health programs, such as HBHC, COHI, the PLAY program, as well as some RNAO initiatives. Our mandatory program funding is currently covering 1 million of our COVID-19 and COVID-19 vaccine costs to date. So we've only had to utilize 500,000 in the COVID-19 extraordinary funding that we were approved for. And we still have additional COVID-19 funding that's already been approved by the Ministry of Health that we can use if required. Looking at our funding and our revenues for the month of May, year to date, our Ministry of Health funding is slightly below budget. That's just a timing difference between the mitigation funding of what was approved and what we've received to date. But the actual funding and budget should align by year end. The COVID-19 extraordinary funding, we've required less of that to cover our expenses. And this ties into our under budget wages and benefits and some of our operating expense lines as well, such as PPE and materials and supplies. We should see a large increase in our direct from client revenue in June when we record our second quarter vaccine revenues. And lastly, with the structure of our banking, the recent prime rate increases have benefited us. So we started to see some additional monthly interest income, and we'll probably see that variance grow. So we'll have more revenue than originally forecasted between now and the end of the year as those rates continue to climb. On the expense side, our wages and benefits continue to be under budget as we have not required the overtime that we originally thought we may have at the start of the year when we were budgeting. Our building and occupancy costs are right in line with our budget. And our operating expense lines continue to be under budget, but I do know all the program managers are closely looking at all their individual program budgets and making plans to spend and utilize their budgets for yen. So we should hopefully see the variances in many of those lines go down before the end of the year. For the capital projects, the Owen Sound Clinic is now completed and the dental team has moved on to the Walkerton project. We have established a project team for that renovation, and right now they're just in the preliminary planning stages. They are currently visiting various locations in the Walkerton area, looking for a space that will work for the new clinic. Any questions?
Thank you. Are there any questions for Kim? Helen Claire?
Thank you, Madam Chair. Through you, the report demonstrates excellent financial management. And I'm just wondering if we can anticipate a media release to go out. I know members of the community are always particularly interested in finances, and certainly the health unit has been under the microscope. So such a press release, I think, would be a good idea. Thank you.
Dr. Aaron, comment?
Madam Chair, we definitely have a list of items for communication. I believe we put out a media release about the finances and the extraordinary actually accomplishment of the finance team and other teams a few months ago. I will definitely run the idea by the communication coordinators. There could be the need for adjusting frequency. If we can put something earlier than what was planned, we can definitely put that as well. I know that they read the social media and the media better than what I do, and I'll follow the recommendation. If it's a good time to put something related to the same subject we published on in March, we will do that as well.
Helen Claire?
Thank you, Madam Chair. And a follow-up to that, some of the concern expressed over the last couple of years to the health unit, unfounded, is with regard to our the female complement of staff that we have. And here we have an example of a senior level female staff doing an extraordinary job. So that could be something as well as an angle. Thank you, Madam Chair.
Very good. Any other comments or questions? I need a mover and seconder to accept the financial report for May 2022 as presented. Moved by Alan, seconded by Helen Claire. All in favor? That is carried. Thank you. Thanks, Kim. Okay, item 10, we have an in-camera meeting. It has been recommended that the Board of Health meet in closed session in order to consider personal matters about an identifiable individual. I need a mover and seconder to go in camera. Then I will take Ryan O'Leary and Brian Millen. All in favor? That's carried. And